Hello and welcome. I'm Karen Walker. Today we're talking about cancer, what it is, why it develops, and how it is detected and treated, and what patients and families need to know when facing a diagnosis. The American Cancer Society estimates that more than 20,000 Arkansans will be diagnosed with cancer this year. While cancer continues to affect individuals and families in every part of our state, advances in prevention, detection, and treatment are helping more people live longer after a diagnosis. Cancer is not one disease, and each patient's experience is different. Today, experts from UAMS will help us understand how cancer is detected and treated, how patients and families can find support, and how advances in cancer care are offering new reasons for hope. Joining us are 5 experts from the UAMS Winthrop P. Rockefeller Cancer Institute. Dr. Omar Atiq, medical oncologist, Dr. Sanjaya Viswamitra, diagnostic radiologist, Alex Wadley, certified genetic counselor, Carla Green, licensed clinical social worker and certified oncology social worker, and Jael Hastings, also a licensed clinical social worker and certified oncology social worker. Later, Matthew Kovak, UAMS Clinical Trials Office Director, will join us virtually to discuss clinical trials and their role in cancer care. Thank you all for joining us for this important conversation. We also want to remind viewers that today's discussion provides general information and does not replace talking with your healthcare professional about your individual health and medical care. We are so excited to have this conversation today. Welcome, everyone. So let's get started. Dr. Teek, let's start with you. Can you tell us exactly what is cancer?
So cancer is a term which is utilized for over 200 different diseases. Our bodies have trillions of cells, and each cell goes through millions of multiplications every day. During that time, somewhere there are mistakes, if you will, which we call mutations that occur, that change the regular body cells into cancer cells. The difference between the two would be the normal body cells know when to grow, when to rest, and when to die. The cancer cells don't know that. And so they continue to grow and continue to invade surroundings and even travel to different parts of the body. So that in general is how cancers occur. All these 200 plus different diseases in various people for a number of different reasons, which would include inherited genetic mutations, which would include mutations that happen over time, which would include environment, which would include personal lifestyles and habits, especially tobacco use, alcohol use, and other viruses, which cause or at least lead to a higher risk of various cancers.
Thank you. So can you tell us a little bit about what happens once someone receives a diagnosis?
Whenever any patient, because of their symptoms or because of screening protocols, are found to have cancer, they are generally referred to an oncologist. Oncologists are physicians who specialize in management of various malignancies, and now we have different oncologists for different cancers who specialize and focus on different illnesses. When they come to that oncologist, along with the team, which includes nurses, social workers, genetic counselors, we have our fellow physicians like radiologists, pathologists, all of us get together. We first want to figure out where is the cancer arising from, what's the site of origin. There we do a biopsy, which is done generally by either interventional radiology or a surgeon, for the most part. Pulmonary or lung cancer physicians and gastroenterologists or stomach and colon cancer physicians also do biopsies. But a biopsy is done to find out the type of cancer. Then once that is done, nowadays we would also send that specimen for something called next generation sequencing, which leads to what is usually called personalized care, if you will. Along with that, we would order various types of blood tests, not only to look for evidence of cancer, depending on the type of cancer, but also to look at other body organ functions, like the kidneys, like the liver, which are important in terms of management. And then one of the more important things that we order is imaging, X-rays, CT scans, MRI scans that our colleague Dr. Viswamitra is going to talk about later. With all of that, we want to determine the site and the type of cancer, whether or not the cancer is localized, whether or not it has gone to lymph glands called regional areas, whether or not it has spread. Because the management of cancer would involve all of those characteristics besides the patient's wishes, which are the most important factor in how we manage cancers.
Yes, that's good information to hear. One thing you mentioned was genetics. Alex, can you talk to us about what role does genetics play in cancer?
I mean, genetics is a huge role, right? All cancer is genetic in some way, shape, or form. The majority of the time, the genetic mutations that occur happen at random and are acquired over a person's lifetime. But roughly 10% of cancers have that hereditary component, meaning they were inherited likely from a parent and are being passed within the family. So for thinking about genetic testing, it can certainly play a role in a patient's treatment and management, but also have larger implications for family members and setting them up for success for screenings.
Well, why does the diagnosis matter to the family as well as it does to the patient?
Absolutely. So if we're thinking that there is an inherited genetic mutation that's being passed within the family, say for a parent who was recently diagnosed with cancer, they've come and seen us in the cancer genetics clinic for a risk assessment, we've ordered testing, we've identified the why, perhaps. They may have developed cancer, but then we know, okay, this is something that not only impacts the patient sitting in front of us, but can be passed on to the next generation. So it can impact their children and other close family members, thinking about siblings, nieces, nephews, for example. And all of this is about early detection, right? So if we know that there is an inherited genetic mutation within the family, early testing can help to identify this patient tested positive. We want to screen them more closely so that way if they were to ever develop cancer, it's caught at the earliest sign.
When do you recommend that people start having screenings for cancer?
It really is. So adding on to what Alex said, it's very important what she has said is that sometimes we can also use genetic counseling for prevention of cancer, like patients who are at a high risk of, say, breast cancer with something called BRCA mutations. They can have mastectomies and or hysterectomies, bilateral salpingo-oophorectomies, which is essentially using, removing the organs where the cancers can occur, depending on the risk of cancer. And as you mentioned, we can also then determine the screening for that high-risk person, which would be the family, and it can be done earlier. So screenings are generally recommended for patients at various ages. For example, breast cancer, mammography or MRI scan, and Dr. Viswamitra is probably going to add to that, is generally started on an average person around age 40. And then the colon cancer screening was started at 50, but now there is evidence to suggest that it should be started at 45. And there are various types of cervical cancer screening is done much earlier. and in fact can be prevented with the vaccination. So various cancer screenings are done at various times where it has been determined by data that that can prevent mortality or morbidity. Going into the details probably would be better left to a person talking to their individual physician about it.
Yes, that's
And
good
you
to
know,
hear.
when we meet with patients, they have so many questions a lot of times on, am I going to pass this down to my other family members? And so I think it's just so very helpful that they can get those answers from a specialist.
Yeah, meeting with a genetics professional, such as a genetic counselor, is integral. You know, we work as a team at UAMS, and when we think about how one person's test result can impact not only their treatment and downstream screenings, but also for their family members, and that can involve a lot of emotions, right? Guilt, anger, sadness, anxiousness, and you know, relying on our colleagues in social work, right? And it can be so important.
So it is real important that there's always a team to help.
Absolutely.
So can you tell us, doctor, what role does biopsies and imaging play in the cancer journey?
Sure. Thank you, Karen, for that question. As you heard from Dr. Atiq, there are, cancer starts in one small location, and typically to identify the type of cancer, as he mentioned, you do a biopsy of that particular area. You also heard from Alice that, there are certain predisposing features or factors that might make a person, become more prone to cancer as well. So if you just look at the two cancers which are often spoken about, that's breast cancer and lung cancer, just as an example. And you have excellent screening programs which are in place to diagnose them early. The earlier you detect a cancer, the lower the stage of that particular cancer is, and what that simply means is that it is in an area which can be treated accurately and aggressively with minimal invasive methods, and that will give the patient the best chance of survival. Is just a general word that we use, but quality of life also becomes very important in that situation. So if you just look at those two major cancers, just to give you an idea, or give your audience an idea about screening programs, mammography is something Dr. Atiq mentioned we typically start at the age of 40 in women in generally. But you might want to start that earlier if they have a family history of breast cancer, or if they have some genetic predisposition to breast cancer, then those women might need to start even earlier than 40 years. And then we do it yearly when you go through the breast cancer program. UMS has a fantastic breast center, and Dr. Brian Smith, who is the chief of the division, is passionate about making sure that women are well taken care of. So part of the thing about screening for me is you're taking a person, they're not a patient yet, you're taking a person who comes in without any history of cancer, and you need to treat them right, you need to make it comfortable, the environment where they get these exams need to be comfortable, and Dr. Brian Smith is fantastic at doing so in the breast center, just as an example.
That's good.
If you take lung cancer screening, it's a little bit different. So with lung cancer, we look at people, again, who have a history of smoking. That's the main predisposing factor. And if they smoke more than 20 pack years, that's 1 pack per day for 20 years, or 2 pack per day for 10 years as an example. And if they smoke, and if they're between the age of 50 and 80, they have a higher risk of getting lung cancer, and they get what we call a low-dose CT scan to identify nodules in the lungs, which are then looked at by the oncologists, and they're then treated appropriately as well. Again, UAMS has done a fantastic job in trying to look for these people who have a higher risk of lung cancer. we have also invested in certain softwares, which can, AI softwares, and I'm sure that's going to come up at some point in this discussion, which can identify these small lung nodules, make it easier for the radiologist to find these nodules in the lung. So this is two examples of screening programs that can be done.
That's
You mentioned
wonderful.
biopsy, and biopsy, again, as Dr. Atiq has already mentioned, is part of the interventional radiology program, or the oncologist, or selectively by the respective surgeons or physicians who are looking at particular organs. It's become so organ specific nowadays. Did I answer your question?
You did, and I'm excited to see that you guys are taking advantage of the advancement in technology, even using AI. Carla, can you tell us what your role in helping families when they receive a diagnosis?
Yeah, absolutely. Well, Jael and myself both work through the Cancer Center over at UAMS, providing support to our patients and their families when faced with diagnoses and treatments and the whole component and aspect of cancer from day one to 5-10 years after a diagnosis, providing support, providing resources, just really listening. And sometimes that's all a patient or a family needs is some time to talk about what do they understand, what have they been told, how do they feel, and like Alex said, there's a bit of a guilt component when it's a genetic component to a diagnosis. Then it's just a matter of providing them with some support and validation and trying to help them through that process.
That's good. That's good. We know it takes a team. How does a doctor develop a treatment plan for a patient when they've been diagnosed with cancer?
So, besides our people who are on this panel, radiologists, licensed social workers, geneticists, genetic counselors, we have our nursing staff, we have other colleague physicians, surgeons, radiation oncologists, medical oncologists, we have pathologists. We have whole teams for individual cancers. We get together usually once a week to look at all new patients who have cancer, or all patients who have had cancer but have had a change in the biology or the aggressiveness of the cancer, or if the cancer has come back. So we all look at that in what is called a multidisciplinary tumor board, which is specific in general in the state of Arkansas to UAMS, from all I know. And we talk through the best way to manage that patient. One thing that is critical is that we don't treat cancers, we treat patients with cancer. And all patients should know that when they walk into our clinic doors, for all of us here and those who are not here, that is the highest privilege and honor that we get when a patient or a person puts his or her life in our hands. And so we try to rise up to that station by making sure that there are multiple physicians, nurses, respiratory therapists, our geneticists, genetic counselors, licensed social workers, that we all give our experience for that one person and their family to be able to get the most out of the treatment. That may include chemotherapy, which are medicines for cancer. There are hundreds of medicines that are all called chemotherapy, which doesn't mean they're the same. Then more recently, we have added other group of medicines that have changed the paradigm of cancer care, called immunotherapy, and something called targeted therapy that has become available because of the next generation sequencing or sequencing of the genome of cancer, which are specific for specific mutations that we talked about. And then there is radiation therapy and surgery. So we determine what is needed for we all of us together determine what's best for the patient, how should it be given, and then we talk to the patient and the families. There are patients who have different priorities. There are patients who have different stations in life. There are patients who want to do it differently. Our job is not to tell the patient what to do. Our job is to provide information in a way that is understood easily. That's our job. And then have the patient decide. And if they need our help in that decision, of course, we are there for them. So that's how this goes in a nutshell, in a brief overview of it.
Yes, that's good information, because a lot of times we don't really understand sometimes how you develop those plans and how you decide. So how do you support families once they have the diagnosis, and let's say they're going through chemotherapy, and it all can be overwhelming for families?
Yeah, so oncology social workers, I think, can really be an invaluable part of a patient's care team. So social workers can come in and they can provide support. They can also help and connect with resources. So with transportation, that can sometimes be a big barrier. And social workers can explore, are there local resources, such through the Area Agency on Aging, or with the American Cancer Society Road to Recovery program, or through insurance with Medicaid or with Medicare Advantage plans. Social workers can come in and they can help with lodging. A lot of people come from out of town for treatment, and so social workers often have a list of local lodging resources that can talk about different amenities that are there to help with maybe shuttles and getting back and forth, or with hospital discounts. Social workers can also help with finances in exploring, are there any cancer-specific grants that are out there, or are there any medication assistance programs that can help? With work, there can be big changes in work. And so social workers can often help in educating about topics such as the Americans with Disabilities Act and workplace accommodations, or talking about FMLA or Social Security disability. If there is a loss of insurance, a lot of times social workers can help talk about what are other insurance options that may be out there. For caregivers, social workers can provide supportive counseling. They can help with practical caregiving tips. And they can also, help refer to support groups that may be out there. So really, social workers, I think, are good at identifying needs as well as providing support and helping connect with resources so the patients and their families can focus on treatment and recovery.
I think caregivers are so important in this paradigm when you're treating people. I've walked through the Cancer Institute a couple of times, and you'll see signs there saying, if you need any help, please reach out to so-and-so. And I think that's very important. We all know families who, the patient, of course, goes through the brunt of it. But caregivers sometimes are local, sometimes they have families, and they're in different locations. And they all need help. They all need support. It's something no one prepares you for. And I think what you said was so important in terms of being helpful for caregivers as well.
And that's throughout the trajectory of a diagnosis and a treatment. Oftentimes we have our myeloma patients that are in the hospital sometimes for a month, and it's just a matter of providing the support to not only the patient but the family. That sometimes we have patients that are coming from out of state, so it doesn't make sense for them to drive back and forth. They're staying there at the bedside with our patients for that amount of time. So just being able and being available to them in that moment is integral.
How long can a family expect to receive support from a social worker?
As long as the patient is active in our cancer center, there is a social worker available.
No time limit.
No time limit.
Isn't that amazing? Because chemotherapy is pretty brutal to the body sometimes, and it's hard for them to really just take in what's going on there. So all having a team is so important. What do you find is the most rewarding thing that you do at your job right now? Anybody? What's the most rewarding part?
As has been mentioned, in our country, the richest country in the world, we don't have a functioning healthcare system. We have a sick care system, which is almost chaos. And so social workers and others actually fill that gap in a way that couldn't be filled without them. When any person receives the diagnosis of cancer, that's not his or her fault. It's a disease. It's not a punishment. It's not the result of any behavior, although behaviors could increase the risk. But nobody wants to get cancer. So I think it's critical that patients and their families realize that. But the problem is that cancer and its treatment, as you mentioned, whether it's chemotherapy, radiation, surgery, is intense or could be intense. It affects the person, their work, their family life, their relationship, their finances. There's an emotional toll. There can be a familial toll. If there are young children, that can be affected in significant manner. And all of that goes into the discussions with our team, with the patients and their families, to give them their best hope. Chance of cure, if possible, which is happening more and more and more with recent advances. The chance of symptom control or palliation, if cure is not an objective at the time. And providing emotional support and holding hands and letting the patients and families know that we will always be there. And that's why, all of us here and those of our colleagues who are in their clinics, whether at UAMS or elsewhere, we are their healthcare professionals. We are not healthcare providers, which is a transactional term, whereas our relationship with our patients is transformational. Because the patients, if they get help, we get help too. And so all that goes into the care that we provide at Winthrop P. Rockefeller Cancer Institute, at UMS, and at other places, frankly. And we try to do the best we can under the circumstances that sometimes could be beyond our control and certainly beyond the control of the patients and their families.
Phenomenal. We're going to take a short break, and when we return, Matthew Kovak will join us virtually to explain how clinical trials fit into cancer care, when they may become an option, and what patients should know before participating. Welcome back. We've been discussing how cancer treatment is tailored to each patient. Clinical trials may also offer access to new approaches to cancer care. Joining us virtually is Matthew Kovak, Executive Director of the Clinical Trials Office at UAMS Winthrop P. Rockefeller Cancer Institute. He'll help us understand how clinical trials work, when they may become an option, and what patients should consider before participating. Matthew, thank you for joining us. Let's begin with the basics. What is a clinical trial, and how does it fit into cancer care?
Good morning, and thank you so much for having me. Clinical trials are an integral part of a cancer diagnosis. Clinical trials are done to learn about new procedures, new treatments that can be then eventually become part of standard of care. I think it's Dr. Atiq really hit it on the head earlier when he was saying that UAMS being a academic medical center, having that multidisciplinary team and including clinical trials in that is extremely important. So, it's not just the, something that is considered once all treatments have been exhausted. It should be something that should be thought about up front. And I think that's where our team sits with that, being part of the tumor boards, making sure that our portfolios of clinical trials are available to all the disciplines to be able to make those important decisions.
That's good. So, Dr. T, can you tell us at what point in the cancer journey do you recommend a clinical trial for a patient?
Great question. So as Matt was explaining, clinical trials are an integral part of management of cancer. So we have come a long ways from even 30 years ago. Our cancer mortality rate has gone down by 30% in our country, which is wonderful. And it is the result of clinical trials helping us improve cancer care. So even now, not all patients are cured. Eventually, we want to cure all patients. And clinical trials are the means to help us get there in an organized fashion to where the benefits of the trial outweigh the risks for the patients. So most of us, for almost all of us at UAMS Winthrop P. Rockefeller Cancer Institute, clinical trial is always the first consideration, simply because that is what can become the standard of care tomorrow. The clinical trials are exceptionally well designed, are very critically monitored, not only by UAMS and our what we call the Institutional Review Board, or IRB, but also by the National Cancer Institute and other agencies, to make sure that the patient's best benefits are protected. So, in surgery, for example, we want to have new surgical procedures that are less invasive and still reach the same effectiveness that the current procedures have. So we need a clinical trial for that. In radiation oncology, we want to have lesser radiation to reach the same outcome. So that is done by a clinical trial. In chemotherapy or systemic therapy, whether it's chemotherapy, immunotherapy, targeted therapy, we want to reduce the adverse effects, also called side effects. But we want to improve the quality of life and eventually the quantity of life, or the longevity. That is where clinical trials come in. So for most of us at UAMS, or almost all of us at UAMS, clinical trials are the way to go if they are available. Now, we do not have clinical trials for each and every situation, but wherever we have those available, and we have them available for a lot of situations, that's the way to go. And Matt and his team in our clinical trials office do a tremendous job of helping patients and their families on explaining the clinical trials, giving their pros and cons, because it has to be an informed decision by the patient. And the patient should also know, that Matt would probably come to in a minute, is that they can refuse a trial and still get the best standard of care, but they can also come out of the trial at any time, with or without a reason. So at the end of the day, we want to make sure that we do what's best for the patient, but the patient perceives us as that. And the patient's wishes remain paramount. They are always in control. So we consider them in pretty much any and all situations.
That's good to hear. It's a patient first mentality.
Without question.
That's beautiful. Matthew, can you tell us some misconceptions that people have around clinical trials?
I think there are a lot of misconceptions around clinical trials, and I think education is extremely important. That's something that we're really striving for at UAMS, not only for the Central Arkansas area, but throughout. One of the misconceptions is you're, a guinea pig that you're, being tested on. And, as Dr. Atiq alluded to, everything goes through a stringent review process. At UAMS, we have multiple layers of approval before a study will be activated. And I'd like to say, that you're getting an added layer by being a participant on a clinical trial. you're not only, you're not losing the current doctors, the current healthcare team that you have, you're getting an additional layer of clinical research coordinators, clinical research nurses, and 50 more back-end people that you didn't even know existed, but are helping work on to make sure that clinical trials are safe. Another thing that I hear a lot on is, I don't want to, get a placebo and not receive any treatment. In the cancer world, you are not ever going to receive anything less than standard of care on a randomized clinical trial. If you're randomized to the investigational arm, you will receive that investigational agent, and then the other time you will then receive standard of care. You will never just receive a sugar pill or anything like that and not receive any care for your cancer. And I think that's extremely important for everyone to understand.
That's good to know. Good to know. So, Dr. V and Alex, tell us a little bit about how genetic testing and imaging, what role does that play in eligibility for patients and even in a measure of response?
Sure, I can talk to the testing piece. So each clinical trial will have its own eligibility requirements depending on the specific cancer diagnosis, the pathology, the staging, and then genetic testing might be recommended to help kind of rule in or rule out if a patient may be eligible for a clinical trial. And with genetic testing, there are kind of two avenues that can be taken. One that Dr. Atiq first spoke about would be testing of the tumor itself or the cancer itself. And a patient may have a specific genetic finding that would make them eligible for receiving, certain treatment from that clinical trial. But then we also think about germline tested, which is the testing where patients undergo through our clinic through blood or saliva, and determining if there's an inherited genetic mutation. And sometimes that can also make patients eligible for certain clinical trials. So it's integral, right? And thinking about the treatment on the front end, but then also kind of downstream effect.
That's great. That's great. What about you, Dr. V?
As you've heard so far, we strive to have a patient-centric approach in whatever we do, and imaging is pretty much along the same lines. When we spoke about screening, for example, we spoke about mammography and low-dose CT scans. When you talk about diagnosis and staging and getting into the clinical trial spectrum, you are at the other end of imaging. So we talk about PET-CT, for example, as one example. Let me talk a little bit more about that. PET stands for positron emission tomography. PET is the acronym for that. And essentially what it does is it's a nuclear medicine technique which targets the cancer cells so that we can see them better across the whole body. And that gives us an idea about where the cancer is in the patient, whether it's localized to a particular area, whether it has spread to other regions as well. So that's one of the things we do. And we can do them at the initial staging when appropriate. We can also do them periodically, either in the regular standard of care or as part of a clinical trial to see how they respond to a particular regimen, a particular treatment. That's one example. Mm-hmm. You can do the same thing with a regular CT scan, with MRI as well. So CT stands for computer tomography, just a fancy X-ray tool that we use where we get a little bit more of a closer look at the individual organs themselves. And we can do that with MRI. MRI stands for magnetic resonance imaging, and each of these have their own specific roles and requirements. Mm-hmm. So that information that we report them in a very structured manner, in a very structured template. And that structure will then give the oncologist a chance to decide whether this person can go through a particular clinical trial, whether that's working, and it becomes their decision at that point of time.
Yes, yes. So Carla, thank you for that, Doc. Carla, tell us a little bit about, the trial-specific demands that come along with being in a clinical study.
Yeah, absolutely. I know there's a good amount of patients who want to come to UAMS who may not live in the central Arkansas area. So oftentimes it's a matter of transportation. How do they get here? Where do they stay? Like Jael mentioned earlier about the lodging options that we have around UAMS through our Cancer Support Center. and just how can we help them attain the care that they want.
So, Jill, do you find that providing care to the patients, that you see them a little bit more at ease, a little bit more trusting that they're getting the best care?
Yeah, I think initially when patients are diagnosed, there can just be a lot of intense and strong emotions. There can be a lot of shock. And so, it's normal to be afraid of the unknown. And that time from when you're diagnosed to getting further testing to waiting to find out about treatment recommendations can just be really overwhelming because there's a lot of unanswered questions. And I think it's important for patients and their families to know that a lot of times in meeting with the oncologist, they can feel a lot better. Just coming up with that plan can be so reassuring. But I think it's also important for patients to know that it's helpful to have a place to go to talk and share their thoughts and feelings. And that might be with a social worker or with a counselor, but that may also be with their family members or friends. I think journaling can be a really great way for someone to get out their thoughts and feelings and really make some space for those experiences. It's important when you're navigating this journey to really lean on your supports. And so, a lot of people in your lives may want to help, but they may not know how to do that. And so if you can give your family members and friends specific ways that they can help, that can be so beneficial. For example, can you give me a ride for treatment? Or can you take my dog for a walk or run to the grocery store for me? So really reaching out for that support is needed.
Yes, those are great practical ways to be a part of helping in the journey. I have another question for Matthew. Matthew, can you tell us what are some of the questions that patients should ask before enrolling in a clinical trial?
Yeah, that's a great question. I think, a lot of times they ask, what's the benefit for them participating in a clinical trial? And I think the best answer to that is, while not common, you could have benefit for the new treatment. You could receive standard of care and have, the normal care that you would if you were not part of that clinical trial. But the real impact comes for the future. We're looking to create new standard of cares and the new treatments for tomorrow. And that's a huge benefit. Another thing to think about are the risks. There's risks associated with, joining a clinical trial. Our clinical research nurses, our investigators go through what, possible side effects could, happen from being on the investigational product. They will go through line by line. A lot of our consent forms are quite lengthy, but we take all the time necessary or all the time that the patient needs to be able to go through that so that they understand. But also understanding, as Dr. Atiq said, that everything is voluntary. At any given time, if they don't feel like this is the right part of their care, they can absolutely remove themselves from the clinical trial, and even the investigator may decide, as Dr. B was saying, if the scans are showing progression, they may need to be removed from the clinical trial and look at a new form of treatment. Other big things, that our social workers do an exceptional job helping with is, travel. Being a rural state, a lot of our participants are coming from long distances. They may need gas cards, they may need somewhere to stay. Some things that we've really been trying to work into our industry-sponsored clinical trials is even things to think about childcare. Things like that is also thinking about the caregivers to make sure that they are considered if they're needing lodging, if they're needing meals, things like that. And then most importantly, always a cost, making sure that they understand, that their insurance company understands that, taking part in a clinical trial, that they could still have their copays. Anything associated with the investigational product would be covered by the sponsor for that clinical trial, but there could still be standard of care costs, and understanding that. And our team, as well as our billing team at UAMS, does the best that we can to help patients understand that.
That's good. So Matthew, is there anything else that you'd like to share with us about clinical trials that we didn't ask?
I just want to reiterate that they're, extremely important part of, a cancer journey. I think at UAMS we're very blessed to have these multidisciplinary groups that are considering clinical trials. If you have questions about clinical trials or cancer clinical trials at uams.edu, you can send us an email. Our website has a list of all of our open clinical trials. It changes daily. And even just, talk to your doctor, talk to your healthcare team. And maybe the place that you're receiving treatment may not have a clinical trial, but they may be able to refer you somewhere that has a clinical trial. And I just think having that forward thinking and understanding the importance of the clinical trials to, hopefully, one day finding that cure.
Thank you. Thank you so much for joining us today, Matthew. We appreciate all the information you've shared to help us understand clinical trials and how they work and the eligibility and all things good for that. So thank you for joining us. We look forward to having a future conversation with you as clinical trials continue to advance in our state.
Thank you.
I would like to add a couple of things.
Please do.
If I may. The adverse effects from any clinical trial are managed by us, all of us as a team. So nobody should think that if there are any adverse effects, that they would be left alone to bear them. No, we would always be there. If there's one of the most important things that we do is to make sure that the patients know that we have their back, period, regardless. The second thing is an example that I would tell you about clinical trials is, many of us know Senator Ben Sasse from Nebraska, who was diagnosed with pancreatic cancer, and it's public, a few months ago, and he was given 3 or 4 months to live. He went on a clinical trial and is doing fairly well, because that drug that he received on the clinical trial has now been approved by FDA for metastatic pancreatic cancer. And he's living, and he's a living proof, and he's very vocal in public about it. So I want the patients and their families to know that no physician, no nurse, no social worker, no genetic counselor would suggest a clinical trial if they don't believe that that's the best option for you, and that they wouldn't, if the situation was reversed, that they wouldn't want it for themselves.
Very good, very good. You know, there's been so many advances in cancer. Can you talk a little bit about some of the advances that have taken place over the years?
Yeah, I can speak to the genetic testing
Yes,
piece.
please.
We're now, I think we're being more proactive with offering genetic testing instead of being reactive. So for patients who are newly diagnosed, they're being sent for a cancer risk assessment. And with our team, we would evaluate their personal risk factors, their family history, and be able to offer genetic testing, which that in of itself, the technology has really exploded over the past decade. There are so many different genes that have been implicated in hereditary cancers, but also thinking about the complexity that we can get with results and having a provider, myself as a genetic counselor, available to help interpret those, I think is integral, but then also being able to pass on that information to the healthcare team, right, and making them aware of that. So with genetic testing, we think about, not only offering it early in the diagnosis, but also for patients who may be at home thinking about, gosh, I have a really strong family history, and talking with their doctor more about that and how they could benefit from a cancer risk assessment themselves, meeting with a genetic counselor to see if genetic testing is something they could benefit from, and then using those results to help guide their cancer surveillance, and then of course testing for family members. So really being more proactive with our cancer screenings.
That's great, and that gives hope, doesn't it?
Absolutely.
Yes. What advances have you seen in the last few years that can offer hope to cancer patients?
Literally exponentially is what I would say. Things are just leaping by leaps and bounds. And a good example, perhaps, is that UAMS is the only certified center in Arkansas to have a SNMMI, and that stands for the Society of Nuclear Medicine, Molecular Imaging, accreditation and certification for therapy and diagnostics using nuclear medicine techniques. Now, some of your viewers may not know what nuclear medicine is, so maybe I can just spend a few
Yes,
minutes
please do.
discussing that. So essentially, if you think about it, you heard about genetics, you heard about cancer cells, you heard that there are different families of cancer cells, and each of them have different targets, as it were. So let's take prostate cancer as a simple example.
Okay.
So the prostate cells, which are carcinogenic, express a antigen called PSA, prostate-specific antigen. And what you can do is you can find a drug which will bind to the PSA receptors, and it can be imaged using nuclear medicine techniques. So the imaging of that PSA study will tell you where cancer is within the body. You can take another drug which has got a stronger localized radiotherapy effect using the same PSA antigen and treat those cancer cells. So that becomes the therapy part of the nuclear medicine thing by using the same antigen but targeting one as a diagnostic study and one as a therapy study. And Dr. Icahn, who's the division chief of nuclear medicine, has done tremendous strides in trying to bring that to UAMS and get that certification. It is available in other places as well, but this is one of the things we are really looking forward to. And there's similar type of drugs for other cancers as well. So it's just an example of where we are seeing increase.
Yes.
If you look at the number of potential drugs that the FDA is on the FDA's table, as it were, in this scheme of things, there are hundreds of them which could be approved sometime in the next 5 years or so. And each of these are then become specific therapy agents, diagnostic and therapy agents for particular cancers, leading to improved care for the patient. That's one of the big things that I've seen. We also do whole body MRI, particularly for multiple myeloma is a great example. And we use PET and whole body MRI to correlate how these patients are doing and to watch for treatment. So imaging is literally, I mean, if you gave me, I could speak for this for about 30 minutes, which I don't think your viewers necessarily require, but it's a huge growth in terms of taking care of the patient.
Yes, lots of advances are going on. As we're coming to the end of our conversation, I want you to think about how treatment has changed and advances have changed over the last 10 years. What message of hope could you give to our audience, each one of you? What would be your final thought to our viewers that are listening now as it relates to cancer and cancer care in our state?
I would think the one thing I've learned in my experience working at UAMS as a social worker is, like you said, the advancement. And to Alex's point, the genetics is so different now than it was 10 or 15 years ago, specifically like the BRCA, that's very important to know whether or not that's something you carry. Whereas maybe 10 or so years ago, that wasn't being tested for. And it's imperative to know those things. And just like the prostate, if you have the genetic component, that's important to know not only for yourself, but your family. And having that knowledge gives you power.
Yes, yes. Who else would like to share a thought?
I'd also say that I think Arkansas is moving in the right direction as far as cancer care is concerned. You have Arkansas Health Initiatives for rural populations. The UAMS is taking a lead in terms of sending mobile mammography units, mobile lung cancer screening units across the state to try to identify people who require cancer care early. You heard from Dr. Atiq and from the entire panel how good and how structured and thoughtful UAMS is in terms of providing the care when the patients choose to give us their trust in terms of treatment. So I think we're moving in the right direction as far as all of that, and that comes from our management as well.
Wow. Thank you so much for sharing. I don't want to cut anyone off. Does anyone else have just a quick final thought for us that you want to leave the audience?
Cancer is curable, and for those cancers that are not curable today, they will be tomorrow. That's the lesson that I have learned in my 35 years of treating cancers. Patients who would have died within months are now living for years.
Wow.
And so there's always hope. And we will make sure that we do the best to get ourselves out of business if we could.
Yes.
And patients should know that their healthcare professionals are all there for them, period. Nothing supersedes that.
Wow. And that's a great way to conclude our conversation. Thank you to all of our panelists for sharing your expertise and helping us better understand cancer treatment and the support patients and families. We are just so glad that we've had this conversation today. So for additional information and resources mentioned during today's program, visit our blog at arkansastv.gov/blog. And remember, today's discussion provides general information and does not replace talking with your healthcare professional about your individual health and medical care. Thank you for joining us.